understanding what queer affirming preventative cancer care and cancer treatment looks like. And for those of you who don't know me, my name is Dr. Upal Basu, and I am the Executive Director of Research at LUNGevity Foundation. I am joined by my wonderful co-moderator, Brandon Leonard, who's going to introduce himself in a second, and three amazing experts who have dedicated their life to making sure that care is inclusive and queer affirming. And before I ask them to introduce themselves, I did want to go over a couple of housekeeping things. The first one is this is really for our queer community and their allies. And if you don't belong to the queer community or you don't identify as an ally, this space is probably not for you. So we ask that you don't participate in today's discussion. Of course, you can stay on, but if this makes you uncomfortable, this is probably not the right space for you. The second thing that I want to tell you a little bit about is how we're going to do this discussion. Please use the chat function to ask us as many questions as you want. And Brandon and I will go through them and ask our panelists to provide their feedback and opinion. And last but not least, I identify as gay and my pronouns are he, him, his. And with that, I'm going to ask Brandon to introduce himself.
Hello, everyone. I'm happy to be here with you all today. My name is Brandon Leonard. I'm the Senior Director of Government Affairs at LUNGevity Foundation. I'm really excited to be co-hosting this discussion with my friend Upal, and excited to hear from these really amazing speakers today. I do identify as gay, and I use he, him, his pronouns. And with that, I think we'll ask each of our speakers to introduce themselves. Dr. Ling, could we start with you?
Sure. Hi, everyone. I'm Pam Ling. I use she, her pronouns, and I'm a general internist and primary care physician. I'm also director of the Center for Tobacco Control Research and Education at the University of California, San Francisco, where for about 20 years, I've done research on tobacco industry marketing strategies, concentrating on how to counteract those strategies to improve tobacco control and cessation programs. And I'm an ally to the community.
Thank you, Dr. Ling. And Dr. Triplette?
Hey, everybody. Maddie Triplette here. Use he, him, or they, them pronouns. I'm queer, non-binary, gay, use all those terms. I am a pulmonologist by training. I work in lung cancer prevention and early detection at the Fred Hutch Cancer Center and the University of Washington in Seattle, Washington, and do a lot of research around engagement, co-design of intervention, evaluation of strategies to help improve lung cancer prevention, inclusive of smoking cessation and screening for at-risk and underserved populations. And that's included a fair bit of work with the LGBTQ community. So super excited to be here with you all for Pride Month.
Thank you, Dr. Triplette. And Dr. Cummings.
Hi, everyone. Amy Cummings. I'm a medical oncologist that focuses on lung cancer and part of the senior leadership at the Johnson Comprehensive Cancer Center at UCLA. My pronouns are she, her, hers. And I've done a lot of work with clinical trials, equitable access to clinical trials, lung cancer screening, and I'm very excited to share that I'm part of the community and I'm thrilled to be with family today.
Thank you so much. To our panelists, Pride is a time of reflection, of celebration of the resilience of the LGBTQ community. And we are very grateful to our healthcare teams for taking care of us and for standing in solidarity with us. And today you'll be hearing from a primary care provider perspective, a pulmonologist perspective, and an oncologist perspective. And you know, from the way we see it, three pillars in care. And so I'm going to start with Dr. Ling, and Dr. Ling, can you tell us a little bit about what the role of a primary care provider is in creating an inclusive care environment for members of our community?
Yeah, I love how you talk about creating an inclusive care environment because while doctors are an important part of this, right, the care environment doesn't only include the physician. So when we think about an inclusive environment, we were just talking about like wearing the pride swag, but I think having making sure that really the whole community environment is welcoming to people is something we need to be thinking about, whether that's having signage that's, welcoming of diverse people, including folks who identify as sexual gender minority, having pronoun stickers or pronoun signs, having photos that are inclusive of all different types of people, including SGM folks. Asking, having all your clinic staff trained to be asking people about things like their preferred names, having preferred names in the electronic medical record, and using terminology that patients use is all, and even being able to ask all patients saying, I want to be respectful. How do you prefer to be called? Is actually a better practice for everybody, right? It's good for my octogenarian patients who I'm not sure if I should call by their first name or not. Or things like having gender neutral or single stall bathrooms is also it's good for transgender folks, but it's also good for people who have caregivers or children who are different sex. And so a lot of things that we do to make the environment in the clinic inclusive is actually better for everybody. In terms of primary care, I think the heart of the primary care physician is really to build a relationship over time, right? So I love that, I've now had the privilege of having patients that I've known for over 20 years. And, for primary care, because you get to know people over a long time, maybe some of those social connections and are even more important. So, knowing who your patient's partner's name and knowing what's important to folks, knowing who the person who knows them the best. So if there's ever any disputes over who should be the durable power of attorney or who should be the medical decision maker, you've had conversations. And as a primary doctor, you can say, I know this person. They've always talked about, their partner as the person who knows them the best. And those kinds of social connections and really building a relationship over a long time is sort of, I think, the starting place for primary care.
Thanks, Dr. Ling. I loved your situating this as, being inclusive of everyone, whether you identify as queer or whether you're an octogenarian. This is just making sure that care is respectful and inclusive of everyone. And the other piece that you highlighted, the piece on relationship and developing that relationship with your patients, loved hearing that as well. So Dr. Triplette, moving to you, and again, we see a pulmonologist as sort of being that really critical bridge, right, between screening and lung cancer treatment. What are your thoughts and suggestions about creating an inclusive care for members of our community?
Yeah, I think that's a really great question. And I really liked listening to Dr. Ling's answer, because I will say from the studies we've done with LGBTQ people around screening that welcoming primary care home to discuss these things, preventive care, health maintenance, is incredibly important. And people look to their primary care provider as, someone they've developed often years-long relationships with. When I see people, it's usually in the setting of finding something abnormal. So I do a lot of workups for indeterminate nodules or things that are suspicious for lung cancer. And I help take people through that very brief but stressful period where they might have found something abnormal. And then at the end, we might be handing them off to Dr. Cummings and with a new lung cancer diagnosis, or we might hopefully be saying, hey, it's something suspicious. We actually found out it's benign. But it's a really kind of what I consider a pressure cooker situation where nerves and stress are running high. And I do find that people's previous experiences of vulnerability and discrimination in the healthcare system often come out because they're not going to their primary care doctor. They're going to a brand new environment with brand new providers. And I think people are justifiably concerned that these might not be welcoming spaces that they're not as familiar with. So something we've tried to do at Fred Hutch as a cancer center is we already know we've got that word cancer in our title, and that's raising emotions high. And so, we've really worked on our signage, and it's also inclusive for communities beyond LGBTQ, that We Ask Because We Care campaign. That hey, we might be asking you a lot of questions during this stressful time, but we're really trying to kind of quickly get up to speed, get to know you and your family, because we know cancer workups, cancer care, those things are going to require a lot of support. We want to know who your support is. And I think that's what the institution is doing. And I think within my own visits, I try to leave it a very open space. I try to let people know right off the bat, the reason why we have these hour-long visits is not to make my schedule cushy. It's because, hey, we're going to use the time together, right? We may need that time together because we're talking about this very stressful thing. I want to know who all these other people are in the room. What does your life look like outside of here? I want to hear from you kind of what you've been going through since you've heard about this thing that you're going through. And then at the end of the day, I want to come together and make a care plan together that feels really comfortable for everybody, and that you understand who everybody on my team is. So I think, as Dr. Ling said, I think these are best practices for everybody, but I think are really important for any of our patient populations that that face discrimination in the outside world, that face discrimination in healthcare settings. They're going to have an extra layer of trepidation. So the more we can make it clear through, directly saying it through these nonverbal cues. Obviously, I've got my pen here too. That this is a safe space to talk about these things, and that actually, if it's okay with the patient, I want to know who your partner is. I want to know what your living situation's like. I want to know what kind of support you are, because I think it's going to be so important as we work together closely during this brief and stressful period of time.
Thanks, Dr. Triplette. I really appreciate you bringing up the pressure cooker analogy and reminding us how stressful this time is. And I think the queer community is already dealing with external stressors of discrimination. I think layered lung cancer stigma and the stigma of smoking. With that, I feel that the matters are compounded. And I'm going to ask Dr. Cummings now to talk a little bit about her perspective as an oncologist, but before we do that, I hope that our viewers understand that it was very deliberate that we asked Dr. Ling, Dr. Triplette, and Dr. Cummings to sort of join this discussion, because we are also trying to sort of create what a model medical home can look like for our community. And Dr. Triplette used the word handoff, and so I'm going to hand it off to Dr. Cummings now to tell us a little bit as an oncologist of how we can create an inclusive care environment for the queer community.
Sure. Thank you so much. And there's so much that I connect to in both what Dr. Ling and Dr. Triplette have said so far. And some of the terms you've heard us all talk about, we're talking about home, highly personal things, trust. And really what we're trying to do is make sure no matter who you are, that you are seen and respected when you come through the door. And all of us have sort of the highest commitment, understanding that families look all sorts of ways, people look all sorts of ways. And really, it's our job to make sure that you feel comfortable, because by the time that you get to me, we know that you've been diagnosed with lung cancer and we have a steep hill to climb together. But the most important thing is that we need to do this together. Most of the time when I'm seeing a person for the very first time, I acknowledge that they've gone through a whirlwind, and that's, maybe starting with Dr. Lin, then going on to Dr. Triplette. By the time they get to me, people are usually scared, because when you hear something like cancer, you're thinking, this is my life, this is my family, am I going to make it through? And we're here to make sure that you do. And so, and that's the whole point behind the screening, making sure that we're catching cancers early, that you're getting the proper care at the proper time. And I think for a very long time, the LGBTQ community just hasn't been seen. And so, and just to flip it a little bit, being a lesbian provider, when people come to see me, I get asked about my husband all the time. What does he do for a living? I get asked about my family. And so in any given day, I usually come out at least 2 to 5 times with patients. And so, but whenever I do, and certainly when I've come out with my queer community, there's this moment where it's just like, oh, thank goodness. Thank goodness you can see me and that you know what it's like to be me. And I think that's another reason why it's so important for us to have all sorts of doctors that are practicing. And really, so inclusion starts from within, making sure that everybody is represented and that we're upholding everyone together. And again, understanding and also to empower you, where if you meet a doctor that doesn't feel like the right fit, that's okay. That's probably the most important thing, is to realize that they're not the right fit for you, and to know that there are plenty of other doctors out there. With telehealth and all the access access that we have these days, the most important thing is that we should be creating trust with one another because we're going to go through some tough times together. And knowing that we trust each other and knowing that we feel comfortable with each other, I think that's sometimes glossed over because a doctor is a doctor is a doctor, but that's actually not true. Your doctor's your partner in this, and we're here just to make sure that you're seen, to let you know that there are doctors out there that really care, that are very similar to you and just want the best for you. So I'm really excited to be part of this conversation today so we can go through all of that. Because yes, we have data, yes, we have science, we've all done a fair amount of that. But ultimately, we're here to give you a connection and to let you know that we're here to support you no matter what.
Thanks, Dr. Cummings. And again, viewers, please feel free to use the chat function to ask questions to our panelists.
Well, first, just want to say we definitely have the right group of experts here on this event today to talk about this topic. This is awesome. So Dr. Ling, you mentioned one of your areas of focus is tobacco cessation, and I wanted to ask you about your approach to tobacco cessation conversations in general, and then particularly how do you approach those conversations in a queer affirming way with members of the community?
Yeah, so I do tobacco cessation in my primary care practice, and then I also do my research in tobacco and do vaping cessation and some other work. So I guess people kind of know that I'm like a little bit extra motivated. I'm always like, I love to help you quit smoking. But in primary care, typically, our practice should be to ask about tobacco use every visit, and not just as a matter of routine, but also like when tobacco use connects to concerns. So if somebody, has a cough that won't go away, or if they had someone in their family just had a heart attack, or we were talking about your lipids, right? Those are all opportunities to integrate tobacco cessation into treatments for those concerns. So it's not just like checking the box, I do think it's important, especially with queer folks, to have, but for all smokers, I think that people who smoke or use tobacco products carry a lot of internalized, already feel really bad about it. And so it's hard you want to support folks in quitting, and you want to give a clear message that, quitting tobacco is the most important thing you can do for your health. But you also don't want to just be like, shaming and hounding people all the time, right? And, if patients are saying, I don't want to hear about it, I'm not in a place to hear about quitting, then I say, okay, but I am still gonna bug you about it from time to time. And, when you're ready, we'll make a plan. I also tend to try to approach it with a genuine just sense of wanting to help folks because I know about tobacco. I also ask people like, what brands do you smoke? When did you get started? How did that happen? And to try to get a sense of what patients, not just that they know it's bad, but like, what do you get out of your tobacco use? Is it a way that you connect with people socially? Is it a way to deal with stress, right? Is it a coping strategy? Or is it just a habit, right? And those kinds of contexts for folks' tobacco use can help us think about, either what you need to address to make cessation more feasible, or sort of the context in which you can say, this is a good opportunity for me to bring this up. For queer patients, we know like tobacco use rates are definitely higher. And then there's also higher rates of trauma, mental health challenges. Those are all things that make it harder to quit. And we also know it takes a lot of tries, right? It takes many tries to quit. So sort of saying, we're in the boat together. I want to be supportive. I want to help you quit. You definitely should, but being able to approach it in a way that's really tailored for people and saying like, if you're smoking a lot because you're super stressed out, let's find out, let's talk about how we're dealing with stress, right? And you kind of have to deal with that right before you can get to the, quitting process.
Go ahead,
And
Dr.
sorry, I may just jump in because I think, one of the other things we really want to accomplish here is helping share what's normal and what's abnormal so you know when to advocate for yourself. Because I think in a perfect world, you may just not know when you need something. And that's one of the biggest barriers I think it is to overcome something. We would hope that you wouldn't have to go and seek out everything on your own, but we want you to feel empowered so you know when it's actually really important. And so what Dr. Ling was just talking about, in terms of a smoking history, we do know that that does lead to an increased risk of developing lung cancer, but also it leads to an opportunity to do screening. And so, if you have had 20 years of history, Dr. Ling knows this better than I do, and are in a certain age category, this is something that you should talk to your doctor about to see whether or not you should qualify for lung cancer screening. And as an oncologist, I actually see a lot of cancers that are not smoking associated. And so knowing when something's abnormal. And so if there was one thing that I could leave you with today, it would be if you've had 6 weeks of symptoms, a cough that's just not going away, you're having some weight loss, you just don't feel well, and it's getting worse as opposed to better over 6 weeks, that is always a reason to visit your primary care doctor so they can start doing some digging to figure out exactly what's going on. So sorry, I wanted to jump in before I forgot that.
No, that was a great point. Thank you. And before we turn to Dr. Triplette, Dr. Ling, I just wanted to follow up on one thing that you mentioned there, which was the higher rate of tobacco use among the queer community. And I wondered if you could talk a little bit about your research and just understanding the impact of the targeting of the tobacco industry on the community.
Yeah, sure. So I did want to follow up on what Dr. Cummings said about screening, because, again, because of stigma, people will tend to minimize how much they're smoking, right? But you only qualify for lung cancer screening if you have the 20 pack years and you're currently smoking or have quit within the past 15 years. So if you're trying to put on a good front and say, oh, I don't really smoke that much, right, then you might actually be disqualifying yourself from lung cancer screening. So it's, again, important to be able to have a relationship where you can be honest about really how much you're smoked or that you are smoking, because that will change whether or not you might be offered, right, the lung cancer screening under current guidelines. My research is on tobacco marketing. And the one thing that it's really, again, brought home to me is that, there are definitely higher rates of tobacco use among queer individuals. But also the work that the tobacco industry does really tells us that, higher rates are not solely because individuals are making bad choices, right? The tobacco companies and the marketing creates environments where tobacco is normalized, where it's a part of social life, where it's freely available and it's really cheap. And then things like targeted advertising and, in media, really reinforce or even celebrate tobacco use as kind of a part of culture, a part of social life. And so, these higher rates of tobacco use are both, related to discrimination and social position, and they're the product of an industry actively working to promote tobacco use in this community. So though it's important to do individual counseling, really to take the research to me highlights that to reduce tobacco use, right, you cannot just have individual counseling efforts, but you really need to be thinking about community level efforts, things like supports for, queer people who use menthol cigarettes, like much more than the average population, right? So policies like the banning menthol products, which, the FDA has been considering doing since 2009 and still hasn't taken action. But things like that actually would disproportionately benefit African American smokers and sexual and gender minority folks. So thinking about how smoke-free environments and even advocacy for things like tailored cessation programs and the things that kind of serve our brothers and sisters and community as a whole are also really part of tobacco cessation and not just individuals.
Dr. Ling, thank you for sort of validating the experiences of our community and reminding us how the community has been consistently targeted by the tobacco industry, and that there's definitely a lot of work for us to do. But I think the first step is just sort of acknowledging that we've been systematically targeted, and that there's no, like, just a validating the guilt and the shame that the community has felt for decades at this point. And I did want to kind of share that the audience really appreciated you using the words, "I would love to help you quit." You use that during your when you're talking about tobacco cessation, and someone said that they would, if their doctor said that to them, they would feel really happy to kind of get involved and feel that their doctor was a partner in this experience. So again, we need to kind of clone those types of discussions that you just talked about. I did want to also ask all three of you a question, and Dr. Ling, you started this, so maybe we ask you this first. You brought this piece up about also mental health, which is equally important in these discussions. So how do you integrate mental health discussions in your encounters and when you're talking to your to patients who identify as queer? And I'd love to sort of hear the same from Dr. Triplette and Dr. Cummings as well, that how do you bring in that mental health piece in your conversations? So let's start with you, Dr. Ling.
I think mental health can come up again in primary care, right? We also, especially for queer patients, we always need to be asking about mental health because there are higher rates of depression, anxiety, trauma, PTSD. I think in terms of tobacco, mental health often comes up because, if you ask what are the situations where people are using tobacco, or what are the barriers to stopping, a lot of times it has to do with managing mental health symptoms. One of the treatments for tobacco cessation, bupropion, which is not the best one, but is an effective treatment, is also an antidepressant. So sometimes trying to align treatment for depression and treatment for tobacco cessation, that's an opportunity, I think, to align those two kinds of interventions. And if somebody is facing, the other thing we know is that if someone has a mental health challenge, a lot of times that is when folks relapse into using tobacco again. So trying to be attuned to the sort of the context of tobacco use is often a natural way to get into the mental health space with folks.
Thank you, Dr. Ling. Dr. Triplette and Dr. Cummings, did you have anything else you'd want to share, add?
Yeah, I mean, I might just speak to kind of when we're addressing this in a screening context. I mean, one of some of the work we've been doing with LUNGevity for the past 3 years is really trying to build a tailored program for lung cancer prevention for queer folks. And that started with formative work, working with community partners. Hey, let's talk to folks that are kind of lung cancer screening eligible or currently smoking. What do they really need? And then that's gone all the way to kind of piloting a navigation model. And part of the reason why we ended up going with a navigation model where we're kind of connecting LGBTQ folks that smoke and are eligible for screening with a navigator who can help kind of hold their hand through the process is because there is a lot of stress involved in what we're talking about. And it's multi-layer, right? I think as Dr. Ling said, a lot of people are affected by the smoking related stigma. They might not want to disclose that. They might worry about quitting smoking even, and the impact that will have on their mental health. They might worry about screening because a lot of people do worry about downstream findings and they'd rather just not know, or at least they feel that way. So actually having that navigator who can kind of unpack that with folks, who can provide tobacco treatment support, help guide people through a screening process that's sometimes intimidating, right? I mean, I think we take it for granted that, oh, it's just a chest CT, just go get it. For a lot of people, that's an intimidating process. And so I think there's so many barriers, of which all those mental ones, whether it be stigma, worry, some element of fatalism related to smoking behavior, they're all tied into that. And so the model we built is really having someone that can connect one-on-one. Of course, what the patients also told us was, hey, I still want my primary care provider involved. That's somebody that I trust, and that's great. But as Dr. Ling knows, sometimes, those 12-minute visits that you can have in primary care to cover a ton of things, they don't provide everything. And so that's where the navigator, who was a tobacco treatment specialist, played into it. So I just say that to say, in general, in our healthcare system, we really shortchange, um, things that are complex, like really effectively addressing smoking, because they do require lots of interaction over time. They do have this mental health component that I think our system is challenged with in the first place. So if you're out there and you're struggling with this, know that, you're certainly not alone. Our system is not the most equipped to deal with it. We have some resources available. I think all of us on this call are trying to create more resources and make sure that they're tailored and welcoming for queer folks.
Mhm. Absolutely. I totally support what both Doctors Ling and Triplette have shared. And ultimately, what we're trying to do is understand vulnerability and how we can best overcome the obstacles that vulnerability creates. And so, whether it's going to be with a navigator, whether it's going to be having access with your smartphone where you can find the nearest center and push a button to get a screening test, all of these things, we're trying to put in place because it shouldn't be as hard as it is right now. And we have to do a lot of work to make it more accessible and to get to the place where it's something that we feel comfortable talking about, among family and friends. And so I think, as we kind of weave in the mental health component of it, again, it's about trying to understand what's normal and abnormal, because you tell anybody that they have cancer, are they going to be anxious? Are they going to be depressed? Yes, that's probably going to happen. That's a normal human response to having distressing information. But is it going to prevent a person from being able to seek appropriate care, where they shut down and they don't get what they need? That's really when we do need to intervene and have those navigators available and help people not be held back by that. And so, and that plays all sorts of ways when you get to the point where you do need lung cancer care. But again, just a nice fact to share with you is that the mortality from lung cancer, again, historically more deadly than the top other five cancers combined, but it's starting to go down. And that's because we have better treatments. It's because we're better at prevention. It's because we're better at finding these cancers early now. So one of the best things that you can do for yourself is, even if you're scared, talk it through with someone who can see it from multiple angles. And again, I think you've heard from all of us on this call today that we're going to meet you wherever you are. There's no judgment here. It's just about how we can best support you at wherever you are. The other thing I'd share is that just because you made a decision at one point in time doesn't, you're not sort of committed to that decision forever. And so if at any point in time where you're like, you know what, I said I didn't want lung cancer screening six months ago, but I may have changed my mind, that is worth a call to your doctor. That is worth a trip to your doctor, because we're never going to say, oh, you said no before. We're going to say, we are thrilled that you have said yes. Let us make this as easy for you as possible. And again, one of the great things about lung cancer screening, no needles, no blood, no IVs. You just go, all it requires is about 10 minutes in a machine, and then you're done. And the scan itself is much shorter than that.
Thank you all. I got a question from the audience that I wanted to pose to you all. So this question says, what are some potential interventions that could be implemented at the community level to help aid with smoking cessation in the LGBTQIA plus community? I think all of you have commented on this a little bit in more of the personal interaction, but from a community level, Dr. Ling, do you want to start with that?
Sure. So I've mentioned a little bit this briefly, but sometimes if we think about policies that affect tobacco use, they can really help the community. So as I mentioned, like the getting rid of menthol cigarettes or getting rid of flavored tobacco products, because those are disproportionately used by members of both the African American community and the queer community and Pacific Islanders, actually, like interventions like getting rid of menthol tobacco products would actually benefit the community. advocacy for smoke-free environments, smoke-free bars and nightclubs, is also a venue where sometimes queer communities have been left behind or not invited to participate in. But again, smoke-free environments are really powerful way to make smoking harder, make it kind of less normal, and also decrease exposure to secondhand smoke at the community level. I think advocacy for tailored good cessation programs for the community and also for there was a whole movement to get quit lines to even ask about sexual and gender orientation questions because for a long time it just wasn't asked, and so we didn't have any data on rates of use and cessation. So sometimes some advocacy on behalf of the community can also improve our care, right? Because then you can realize that, oh, we have a lot of people calling the quit line. Who are a sexual gender minority, and we need to make sure that we're responsive and welcoming to this community. But it actually took a lot of work to get those questions included in the very fast intake. The last thing I will mention is that I do have some colleagues who are young researchers, early career researchers who are interested in an idea of empowerment and empowerment as a cessation, as a support for tobacco cessation. And so they're just did a project where they connected people participating in tobacco cessation who were queer with queer organizations, and to see if participating in an empowering activities with your organization, which is for the community, would also help your tobacco cessation, even though the messaging wasn't exactly about like quitting tobacco, but there seems to be something around empowerment theory. Whereas when you're taking action to benefit your community and to help others or educate others, that kind of helps with these health promoting behaviors. So I can put a link to their pilot in the chat because I'm just super excited about this kind of new research in this space.
Great. Thank you, Dr. Ling. Dr. Cummings or Dr. Triplette, did you want to also comment on that?
Sure. And maybe I'll just jump in because as you kind of are going into like what's the next generation, where are the next things that we're doing to work on the community, I think geospatial analyses are becoming more and more important and just awareness of them. Because if you take a look at the smoking rates, in terms of the number of retailers and the density of retailers in those high smoking areas, it tends to go higher. And so do these things go hand in hand? You walk by 5 places that sell cigarettes that have a big advertisement in the window, and you have 5 opportunities to think, well, should I try that? Do I need to, is that something I should have? And so as we sort of share these information and these data, we can come up with policies and strategies to circumvent them. And so I think, again, there are things that are just a natural byproduct of a capitalist market environment. But knowledge is power. And that's where we start. We start with an awareness of it to come up with strategies and interventions that actually prove that they help. And that's what my colleagues are doing on this call. So more to come from AI.
Yeah, I think I think the community is so powerful. I love that you framed it around community, right? Because empowerment, activism, all these words come to mind when you say community. When we were building out some of our early work in this space, the first thing we did was kind of connect with all the community-based organizations, or what people call CBOs, that are serving the LGBTQ community. In whatever city you live in, even in rural areas, there probably are those organizations who are doing that. And typically, unfortunately, those organizations have to be kind of narrow in their missions. For example, some of the organizations we worked with in Seattle have really taken the lead and have done so since the beginning of the epidemic with with HIV, AIDS, prevention, control, testing, expanding to STI testing. And that has kind of been a huge footprint and a huge service to the community. But other health problems within the community, like smoking and smoking-related cancer, which we're talking about now, it's not that they don't want to address those. It's just, it would take resources that these CBOs don't have. So one thing that we did in our study was say, hey, can we partner with you where, we're recruiting from our studies, from your sites, but we're also providing you all and your community members with services that you don't have. And in that case, that was smoking cessation, access to lung cancer screening. And we found that was a beautiful partnership because, again, it's not that these organizations don't recognize that queer folks that they're serving are smoking. It's just that they're, under-resourced as it is to fulfill the mission that they're delivering to the community. And so those partnerships were great. They also allowed a lot of these discussions to happen in a community space. And I feel like some of the things we talked about today are kind of stigma and isolation. I think a lot of people that smoke feel that personal sense of judgment, and there is something cathartic about talking about it in a community space. So we've kind of been modeling a more community approach to discussions around smoking cessation. We have a really great organization called Gen Pride here in Seattle, where they offer free queer elders lunches. So there's kind of lunch and learn sessions where we're able to talk in community in judgment-free spaces, and we're able to back it up and be able to provide resources and connections to care for smoking cessation and screening. And I think that's a great thing. So what I would say is if people are interested in that community approach, really, if you do take a survey of the queer serving organizations, you'll realize that they are kind of overstretched and they are doing amazing things. And maybe if you're interested in the lung cancer prevention piece, it's like kind of partnering with someone who's interested but doesn't have the resources and being able to provide that piece. That's been a good model for us.
Dr. Triplette, thanks so much for reminding us that collaboration is key. I think we think about interventions all the time, but getting them into the hands of the community, I think to your point, partnering with queer serving CBOs, making sure that they are resourced to deploy some of the interventions that are created in academic centers, I think is really key. I'm going to go back to you, Dr. Ling, and you sort of started this point and someone from the audience brought up this question. You brought up that at some point, the tobacco cessation lines were collecting SOGI data and then they stopped collecting that data. So the question that we have from the audience is really, first, why should we collect this data? But I think equally importantly, how can we continue to collect this data given all of the different opposing forces that we are dealing with right now?
Yeah, I mean, it's kind of funny sometimes to be thinking about like having to advocate for data collection. It sounds very research. But I don't think that the quit lines were collecting and then stopped, but I think it took like a decade for many of the quit lines to routinely ask about SOGI data. And there was kind of this vague concern that it would be like people wouldn't know why you're asking, or that it might be it might offend somebody to be asked if they were calling the tobacco cessation quit line. And so it took a lot of work and advocacy to get like one question, right, included on the quit line intake. And similar to to advocacy that it's taken to make sure that SOGI data is in the electronic medical records, right, as a part of routine, as an important part of routine care. The kind of good thing about that is that usually once you put something in the medical record, it's really hard to change it in the system. So those things can become routinized and then they're hard to remove. But I think in the current context, right, we're seeing a lot of national surveillance public health surveys, right? We're taking down and removing the SOGI data questions. And so we really need to be defending collecting this data, because it's, it feels like erasure of the community when you no longer collect the data. I mean, they're also not collecting the National Youth Tobacco Survey, as far as I know, either. So the whole vaping problem is going to go away because we won't have any more data. But some of these moves to really stop collecting data, stop counting folks, means that it's easier to to have your community or your problem be unseen. So I think especially now we need to really defend collection of these data so that we continue, you can continue to advocate for the community.
Yeah, I was just going to jump in after Dr. Ling and just say that the data is so fundamental to some of the challenges that we're talking about from a population perspective. If people ask, well, what is the difference in mortality between Black patients and non-Hispanic white patients with lung cancer? We can look at nationwide data reported to cancer registries for the past 20 years and kind of give you an answer to that. And when we find that disparity, then that kind of leads to research to say, well, how do we now address that disparity? And the problem with lung cancer and cancer in general, all the way from risk factors to survivorship, is because sexual orientation, gender identity, or what we're calling SOGI data are not collected universally. We know those disparities likely exist from behavioral risk factor surveys, census, other things, and data like Dr. Ling is reporting. If smoking rates are here, then we would expect downstream lung cancer diagnosis survivorship may be lower, but we can't point to that, right? So that data collection is fundamental in our efforts to not only identify disparities, but then go the step further and address them. I think the challenge in this current environment is I would never begrudge any individual person for feeling a little bit of trepidation at revealing their own sexual orientation or gender identity. I think this has been a really nice space for us to, identify where we sit in the community, and I try to do that and model that behavior. But even in my position, that feels like a risk at times, and I think it's worth acknowledging that. And all the things we were saying at the beginning about the welcoming environment are hopefully to help people feel at least informed and supported should they decide to disclose that. But I would never, move to a system, particularly in the current political environment, where it feels like people are mandated to do it. What we want to do is we want to support you to identify yourself because we want to respect you. We want to use the name that you prefer. We want to use the pronouns that you prefer. But we as a medical organization need to continue to advocate within our healthcare organizations to protect that data. I mean, I think we have seen instances where that data is not fully protected, and we as providers, we as organizations really need to make that commitment to our patients when we are asking for their data that can make them feel quite vulnerable and rightfully so.
Mm-hmm. Yeah, absolutely. I think that both of you have said that beautifully. And just to drive the point home, in this data-driven society, we have to prove when we need funding. And we do not get funded if we do not have the data to support it. So by missing it means that there aren't funds that are allocated to very important research that could save lives here, like save the lives of our community. And so for those of you who do feel, brave enough, we have lots of options because I think, again, just acknowledging that no one path feels the most comfortable for most people. And so some of the things that we've done at our healthcare organization is just to have sort of a permanent questionnaire that sits in your electronic database that you could self-identify if you choose to, or you could mark that you don't want to identify and capture that as well. And so, but we, do hope that you would share with us and again, with our commitment to protecting you at all costs and just to help us continue to move forward and to get the funds that we need to make the difference.
Thank you all. I wanted to ask you next, thinking about care for our transgender siblings, they've always been subject to a lot of discrimination and misunderstanding. And I think the current environment that we're in right now has just exacerbated the fear that a lot of people feel in all kinds of settings, including healthcare. I wanted to ask if each of you could talk a little bit about how you approach inclusive care for the transgender community. And Dr. Cummings, could we start with you?
Sure. And I think certainly, there are all types of people who fall in that category with all different actions that support their medical care. And I think the big one that pretty routinely comes up with me are about hormones and hormone usage. And just to say this very clearly, the only data that has ever supported a mortality risk is in postmenopausal women, cisgendered women. And again, that didn't have any impact on the incidence. And I think if you were to untangle a few of those other variables, you would show that, hormone use we see as a life-saving therapy. And I just want you to know that no one particularly not me, would ever take away your hormones because of cancer. And so we've never proven that that's a problem. We don't have enough research. Yes, that's true. But every time we've studied it, we haven't shown any increased risk because of it. So that would probably be, to support people wherever they are. That would be the main thing that I would want to share. And again, I think that, as at all of we work for organizations that are luckily, very supportive, and it comes top down and bottom up, where we have a staff that supports it and a leadership that supports inclusive care. And so I would say, we're very lucky to be practicing in this world, but it also helps us have access to training. So all of our institutions, I believe, have sort of affirming care for LGBTQ plus community. And understanding that, part of that training is, what do you feel comfortable with in terms of physical exam, not forcing anything on you, from the very first appointment. It's going to go at your pace and what you're comfortable with. And just know that we get that training, and that if anybody is not sort of meeting your expectations or your needs, they're out of compliance with our policies.
Thank you, Dr. Cummings. Dr. Triplette, would you like to comment on that as well?
Sure, and I really appreciated Dr. Cummings describing the training that her staff go through, because I will just say in general, and this comes up more with trans patients, I think, than sexual minority patients, is that there's a lot of well-meaning folks throughout the healthcare system that just feel really uncomfortable with some of this. And that can actually be mitigated by just some training, some open forums, some open discussions. I think National LGBT Cancer Network has been amazing at this, at putting together some trainings that our organization has used. So I would point to that as a reference for anybody that's really interested in this space, because I think if you're in an organization or in a care environment where you're not seeing that training take place, that actually a little bit of training and open dialogue can really make a huge difference. And I think where people get stuck is that in some situations, it is important to go down the list of understanding the nuances of people's medical transition care. But for whatever reason, that seems to be where people go first in terms of with any encounter, hormone therapy, surgical transitions, other things. When in reality, in most of the spaces that we're in, the most important thing is creating a respectful and welcoming care environment. And that includes people's preferred name, preferred pronouns, and just a sense of general respect towards people's life, lifestyle, family, all those things that actually, when we did a study of it, nearly every single person in the study recognized all those things are just part of good holistic care practices. So those are the things that we want to create an open forum where people can talk, as Dr. Cummings did, when hormone therapy should come into the conversation, which it absolutely should in some circumstances. But in most medical interactions, we need to understand that it's really the respect and then the unfortunate experiences that many patients, many trans patients have had with lack of respect or being dead named, called the wrong pronouns. Those are those pivotal decisions that either get people engaged in their healthcare or they turn them away from healthcare. So really a focus on those most pivotal things is really key. And some of that can just happens with more comfort with the staff. Again, I think no matter what we're hearing in the news, I think most people in healthcare want to help people. They want to respect people. They believe things like pronouns are important. It just can seem a little intimidating when people haven't had the space and opportunity to discuss them.
Thank you, Dr. Triplette. Those are all some really good points. Dr. Ling, did you want to add anything to that conversation?
I wanted to add in the chat, because UCSF has a Center of Excellence for Transgender Healthcare. So, and including some free webinars and free education materials that are pretty fast and a pretty good resource. I think I agree, like just being a good human and creating a supportive environment is really important. I think when it comes to cancer screening in primary care, sometimes, again, with transgender folks, a focus on transition can sometimes mean that like routine cancer care and cancer screening gets a little bit lost. And so particularly remembering to, again, I think sometimes transgender folks also have a little more hesitancy around, let's say, prostate cancer screening or cervical cancer screening if it involves birth sex anatomy that they're not comfortable with. So sometimes they rely on the primary care or the doctor to bring it up. And to pay attention to some of the routine cancer screening care. I think also thinking about, again, kind of more universally, right? HIV prevention, HPV prevention are also cancer prevention, right? And so having that kind of broader view of how cancer prevention aligns with good comprehensive care is kind of part of our job.
Right. And maybe just one more thing that I'd like to share is that, and particularly at a public California academic medical center, there are some things that have changed on their surface. But what you always see from our leadership and all our communications is that our values have not changed. So just know that at the heart of everything, we would not be practicing in the institutions we're practicing in if they did not support people. And that's really important to us. And that's one of the stipulations that we make to practice where we practice. And so just know that even if it may not be as overt as maybe it's been before, it is at the core of everything that we do. You will always be protected. We have policies in place, so don't worry.
Thanks, Dr. Cummings. And I wanted to share a comment from one of our viewers, and I'm quoting them. Dr. Cummings and Dr. Triplette, we love you, but Dr. Ling, you're extra special. You have set a very high bar for allyship. And I think and just sort of, on that note, I think we would love to clone the three of you, and we wish that every person who identifies as queer has access to the Dr. Ling, the Dr. Cummings, and the Dr. Triplets, but we know that that's not the reality of most patients who identify as queer. So any advice you have for community members who are seeking queer affirming providers? And let's start with you, Dr. Cummings.
Yeah, and so I think so one thing that I would just make sure people are aware of is that there are a lot of things that came with COVID. And one very valuable thing has been very robust telehealth. Routinely, many academic medical centers have virtual programs, second consultation services. And so if you have, a phone or internet connection, we usually can figure out how to have you seen or get an opinion, or if you wanted someone to reach out to your doctor to help them with their management plan. We do this all the time. But, again, I think another thing that we all probably speak to is, continuing to set a good example wherever we go. Many of us travel internationally, speak regularly. And so we're always an open door. So anybody that's interested in, providing affirming care and wants to talk with any one of us, the door is open. Please come find us. We would love to chat.
Yeah, and I just dropped a link in the chat. And I think LGBT providers are in high demand in some areas. So, I mean, I think, it's nice to be able to kind of look within your network and area. But I think also just know that that the visibility of these issues, it is gaining some steam. And I say that to say that I've been involved with kind of the UW Medical School and what their curriculum looks like on SGM patients or queer patients, and it has changed dramatically. I think we had maybe a 1-hour session and 100,000 hours of didactic education, right? And that felt that's the type of thing that gives you more questions than answers and didn't really fill anyone's need. Whereas I think there is a true push toward a curriculum that really supports provider awareness, provider education around the care for queer people. And I think that's great. So I say that to say that, and Dr. Ling epitomizes this, you don't have to be a queer person to take excellent care of queer people. And I think that's what we all need right now. And I'll always take a step back. Any study I'm in, I will say that for the queer patients that I talk to, them finding that primary care provider that they can trust, and just like Dr. Cummings said, sometimes it wasn't a good fit, and they have those stories too. But I think advocating for yourself and acknowledging that if you're feeling disrespected, you probably are, that there's many opportunities there for you to seek other care providers, and that locking in with that primary care provider seems to be a really important driver of getting the preventive care you need, and finding that partnership for your health going forward, which is the ultimate act of resistance, right? During this Pride Month, is taking care of yourself, so that you can then take care of the community and other people.
Okay. Dr. Ling, did you want to add anything?
No, very well said. And I had exactly the same link that Dr. Triplette put in the link. So
Perfect.
that's awesome. Yeah, no, I appreciate this space being made, like, for allyship, because queer providers is really important. But of course, everybody can do a good job. So I think we should all do our best to be good allies.
Well, we're at the top of the hour. I feel like we could continue this conversation for a while longer, because there are so many more topics that we could delve into. You all, this has been fantastic. I just want to say thank you so much, Dr. Ling, Dr. Cummings, Dr. Triplette. I think exceeded all expectations for the conversation that we wanted to have today. We want to have you back, and so Upal and I have talked about making this a series, and so we want to say to everyone, look out for announcements down the road for more conversations like this. And also just want to encourage everyone, if you know someone who maybe couldn't watch live today, but would benefit from hearing about this conversation, whether they're a patient, a caregiver, a provider, a researcher, or anyone who's interested in these issues, please share this with them. The video will be available on Facebook to rewatch or watch anytime. And last, I'm just going to put in one more link, and this is to our forum for the LGBTQ plus community at LUNGevity. We'll be dropping in the resources that were shared here today in the forum, and encourage folks to come and check out those resources and to join the conversation there. And on behalf of my good friend and my new friends here today, I want to say thank you all so much for joining us, and we'll look forward to the next conversation. Take care, everyone, and happy Pride Month.
Thanks,
Thank you,
everybody.
everyone, and happy Pride.